Research Town Hall meeting. Today, we're going to discuss and hear from some researchers on campus that are doing family and holistic research health or health research. And so I'm going to start with sharing the agenda, which just to make everyone aware of the agenda in case you didn't see it, it was mailed out. So we do have a leadership update that I believe Kevin Martin is going to do very briefly. He may not have a whole lot. And then we're going to hear from Cindy Loxon and Danny LaPrise, and then we will hear from, our researchers that are joining us to talk about their research. I think we'll get through this pretty quickly unless everyone has a lot of questions, for each of the researchers. One of the things that I wanted to mention before I forget it, we have decided to not have a May Research Town Hall. However, we will reconvene in June. We just decided May is just extremely busy for everyone. So I'm going to turn it over to you, Kevin.
Thanks, Lee. Yeah, so I'll probably save us 4 minutes here. Don't have much of a leadership update for today. Dr. Gardner's down in Vanderbilt with an NSF tip directorate. He did just want me to express everybody to have a good Derby preparation week and a festive time, and to also express our great appreciation for the presenters today for today's town hall. It's an incredibly important part of our research portfolio, and he just wanted me to share our appreciation for presenting to the group today. So Lee, I'll turn it back to you.
Okay, thanks, Kevin. So Cindy and Danny, would you like to talk a little bit about the new pilot study that we are partnering with on the data management plan?
I will. So hi everybody, I'm Cindy Loxton. I'll give an introduction and then kick things over to my colleague Danny, who will finish up. So UofL, as Lee said, is involved in a pilot study in partnership with the Federal Demonstration Partnership Group. And this is piloting a couple of different standardized data management plans that are now required as of the middle of January for NIH grant applications. So some of our partners in this pilot study are Harvard, Johns Hopkins, and NIH. So we're trying to figure out from this pilot study how we can decrease the burden of filling out this form. The burden is pretty great. It's pretty extensive. And then really to how we can achieve some consistency in the data management plans that are submitted to NIH. So we invite any of you that are submitting NIH applications to please consider being part of this pilot study and to encourage your colleagues to do so. So I'll turn it over to Danny now, who can tell you more details.
Hi, everyone. Thanks for having me. I am putting a link in the chat. We've kind of compiled everything together in our Health Sciences Research Data Management LibGuide. I've added a tab on there that's labeled Pilot Study, and it has all of the study information. There are 2 templates that you can choose from. You can download both of them, take a look, see which one you want to fill out. Choose one of those templates, and then there is a link to a Qualtrics survey. So that goes directly to the group that is conducting the survey. So they collect that data, and that's really it. You fill it out. Like, you have to do a data management and sharing plan for your grant applications for the NIH anyway. So if you use one of these templates, they were both developed with consultations from people from the NIH. So that feedback has been put in there. If you have any questions about any of the templates or anything that needs to go in it, feel free to contact me. But yeah, the study is pretty self-explanatory. Choose a template, fill it out, and then submit your survey.
Thanks, Danny and Cindy. That's a wonderful project that we're able to be involved with so that we can provide feedback. Appreciate you guys leading that effort. So I'm going to turn over this next session and introduce our first researcher, and that is Martin Hall, and he's going to talk about his SMART project. So Dr. Hall, do you mind taking the presentation?
Absolutely. Thank you, Lee, for the invitation, and thanks to everybody else who made time to be here today. I'm happy to serve as the opening act here for Armand and Patrick. So let me just pull this presentation up here. Oops. Okay, so I'm going to talk to you about sobriety, treatment, and recovery teams today. And so I don't think I probably have to say too much about the substance use epidemic in this country, but I will just share one figure with you. And so what you see on the left here of this slide is the mortality rate for overdose deaths in Kentucky. So it's 56 deaths per. Is that me? Sorry. It's 56 deaths per 100,000 people in Kentucky, which is one of the worst overdose death rates in the country. And 100,000 people died in the most recent year, which is the highest number of overdoses we've ever had in this country. So I won't spend much time on that, but I will go from there to say that there are implications far beyond overdose that impacts families in Kentucky and across the nation. And so substance use is present in about half of the maltreatment events that happen in Kentucky. That's higher than the national rate, which is about 30% of maltreatment events in the U.S. So it's a common way that families get involved in child welfare services in this state. When you come into child welfare because of substance use, you tend to have poor outcomes. So more likely to have out-of-home care placements. If you're removed, and that means so if you can't safely be maintained in your home because substance use is so severe that it impairs your parenting, if you are removed, you're less likely as a child to be reunified with your parents compared to other kinds of families in child welfare. So a significant problem in terms of how families get involved in child welfare, and then their outcomes are often associated are more negative when they're involved with drugs or alcohol. So why is removal, this idea of being placed in out-of-home care, why is that something that we should be worried about? So this is a big study that came out of Finland in the last year. And so what you see here are hazard ratios for a number of different negative outcomes for children who were removed. And so in this study, this was all kids born in Finland between 1986 and 2000. They were followed into adulthood. And so because they use sibling pairs, it's a great way to control for genetic contributions and family factors. And so what you can see here is across a range of psychiatric disorders and socioeconomic status outcomes that kids were removed, even when compared to their siblings, tend to be much more likely to have all these significant problems later on in adulthood. So you can see, just for example, severe mental illness is about 5 or 6 times as likely for a sibling who was removed and placed in out-of-home care compared to a sibling who wasn't. And then we have two more categories, and it's really the same story. So injuries and experiencing violence, and you can see on the right here, antisocial behaviors, premature mortality, and across all these serious adult consequences, it looks like out-of-home care contributes a lot, even when we're able to control for other kinds of factors that might explain these outcomes. So this is an important outcome. A program that Kentucky uses to try and prevent out-of-home care is called sobriety treatment and recovery teams. And so this is housed within the Cabinet for Health and Family Services. So it's situated in child welfare. It's for families who come in because of substance use problems. It does a really good job of integrating the child welfare system, addiction treatment, the courts, and other community partners. Historically, these are entities that don't really collaborate and work well together, and so that's a big part of this intervention. The other key part of this intervention is it specially trains a child welfare worker in substance use and a counseling approach called motivational interviewing, which is focused on trying to identify the factors that an individual might have for changing their behavior related to substances, rather than imposing our own ideas about why somebody should make changes in their life. Maybe the most important part of this program is that this specially trained child welfare worker is paired up with an individual in long-term recovery. And so that's what we call a recovery mentor. And so together, the specially trained child welfare worker and the recovery mentor share a common caseload of families. So START is currently in 7 states in the US. I mostly work with Kentucky. It's been evaluated by 2 distinct evidence-based clearinghouses. And so the top one that you see here, the California Evidence-Based Clearinghouse, has START as having promising research. The Title 40 Prevention Services Clearinghouse rates START as supported. And I'm going to tell you a little bit about how we got to this point and our efforts to get to well supported. So I'm going to speak about 2 different studies that we've done today. The first paper at the top, published in Children and Youth Services Review, is a quasi experiment that used propensity score matching to compare families that got START to families who got usual services. And then we conducted a randomized control trial here in Jefferson County a couple years ago. So for the quasi experiment that used propensity score matching, and I'll say a little bit more about what that means for those of you that don't know. So essentially, propensity score matching is a way to establish a comparison group based on a number of theoretically relevant factors. And so essentially what we're going to do, and I'll show you the variables that we use, is to identify variables that we think are important that would have contributed to a child's involvement in START, and then use those measures to match to children who got usual services in the child welfare system. And so our sample was the youngest family, youngest child in each family referred to child welfare services in 5 Kentucky counties between 2010 and 2016. We had 1,042 kids in this study. Our randomized control trial used bias coin random assignment, which is basically means that there's an increased odds of one condition. It's still randomization, still works the same, but it's a little more palatable for people that are not used to randomization, which is if you don't work in the community, selling a randomized control trial, as obvious as it is to people who do science, not an easy sell. And so using bias coin randomization, where we were able to say, okay, you're going to have increased likelihood of families being referred to the experimental START program, that helped. We did this just in Jefferson County, and this was over about a 3-year period a couple years ago, and we had 418 kids in this study. So let me just say a little bit more about this propensity score matching. So these are our 5 different counties that have a START program or had one at this time. And we matched within a county cluster because we didn't want a kid in Davis County to be matched to a kid in Eastern Kentucky. We wanted to have people geographically similar in addition to the other reasons. And so you can see for each of these clusters here that we matched within this geographic radius. So the variables that we use to match for this propensity score matching, we had sort of 3 domains. So there were child variables, so age, racial status, sex. There were case-focused variable like the year that they came in, how the investigation ended, and then a number of family-focused variables, so adult mental health, domestic violence, poverty, criminal history, and of course, substance use. And so essentially what this does is that it establishes a propensity score, which a logistic regression is used to give every child in the sample, and we had hundreds of thousands of kids over the course of this year. And so these years, so we matched a START child to the child who was closest to that START child on their propensity score. The outcomes that we look at are placement in out-of-home care within 12 months of the initial maltreatment event. We look at where kids are at case closure. And so ideally, they'll be reunified with their parents if they were removed. And then finally, we look at subsequent maltreatment, and then this is any substantiated maltreatment that occurred after that initial event. So I'm going to talk about this by color here. So on the left here, you have the propensity score study. And so 21% of children in START were placed in out-of-home care at some point during their case, compared to 34% of children who received usual services. This is the same general trend that you see in the randomized controlled trial, though the percentages weren't quite as favorable to START, 24.7% to 31.5%. These were significant differences in favor of START in terms of reducing out-of-home care. The next outcome of those people who were reunified, of those children who were placed in out-of-home care at some point, what percentage were reunified? And then you can see that in both studies, it's a higher percentage for START, which is desirable, meaning that if you had to be removed, you were more likely to be reunited with your parents relative to usual services. And then lastly, the yellow bars here are whether there was subsequent maltreatment. So any additional maltreatment that occurred in the year after that index event. And you can see here, surprisingly for us, that it was actually higher amongst START in both these studies, though less so in the randomized controlled trial. And we have some ideas about why that was, which I'll talk about. So the main takeaway, placement in out-of-home care, which again, if you think back to those early slides about the connection between placement and out-of-home care and negative outcomes in adulthood, we had lower rates in START, which is an important finding, not just for now, not just for kids in Kentucky and across the nation at this particular moment, but in 20 or 30 years from now. Secondly, we found that reunification was higher than the national, it was higher, first of all, than comparable families who got usual services, but also higher than the national average. And that's an important finding because START is basically built on serving families who are at high risk of not having their children reunified if they're removed, because we know that substance use, that younger age of children, and that neglect versus other kinds of maltreatment tends to be associated with lower odds of reunification, and that's who this program serves. So I want to say just a couple things here about the subsequent maltreatment finding. So there's three reasons we think that START could have higher maltreatment compared to usual services. So the first is that it could be that people who do START don't make as good of decisions about the risk that is present in families. So maybe they just do a worse job of preventing maltreatment. That is possible. The second thing, particularly in the propensity score match study, it could be that we looked like we had a good match. START families match comparison group families on all those 9 categories that I described to you. And everybody looked comparable, but maybe they weren't. You know, we know that all the families in START have parents who have substance use disorder. We can't know that about comparison group families because that isn't in our data set that we get from the state. So it's possible that START families were more severe, but I actually think it's probably most likely number 3 here, and that's that there's a higher level of surveillance among families who get START relative to usual services. So there's a previous study, Barth and colleagues in 2006 found that when you looked at families who are in child welfare, if you got addiction treatment, that actually increased the odds that you'd have subsequent maltreatment. And they hypothesized that this was probably because of increased surveillance. We think that's probably a case here because START has not just a child welfare worker, which typical child welfare cases will have just a child welfare worker. Maybe they get addiction treatment. START actually has a child welfare worker, the individual who's in long-term recovery, who's making regular contact with the family, and certainly treatment providers. So there are a lot more individuals who are working with a group of families and thus a lot higher level of surveillance. There was one study using national data that said that only about 10% of subsequent maltreatment is reported by social services. So they said, oh, it's probably not, surveillance is not as big a thing as we think. But in our study, we found that in our experimental group in START, 38% of subsequent maltreatment was reported by social services personnel, compared to about 18% for the match comparison group. So considerably more likely that a subsequent report is considerably more likely to be made by a social services person for START versus usual services. So this is more evidence, we think, that surveillance is a part of this increased rate of maltreatment. So I think I'm close to time here. So I want to just say thanks to the Kentucky Cabinet for Health and Family Services, the Administration for Children, Youth, and Families who've supported this research, and then the colleagues in the Kent School, as well as the other departments who've helped us along the way, bioinformatics and biostatistics and criminal justice. So thanks.
Thank you, Martin. That is such an exciting work that you're doing, and so, so impactful for society, because, the numbers you showed for, substance abuse, particularly in Kentucky, that's outrageous. I mean, this is a huge problem. And so I really, appreciate you doing this kind of work and sharing it with us. Does anyone have any questions for Martin? One of my questions, Martin, would be, what is your next steps? Where are you going now?
We're proposing another long-term outcome study. So we'd like to know the outcomes that I talked about today are within a year of the initial involvement with START. And so we'd like to look beyond that and maybe go a year after case closure to see what actually happens to families once they're no longer receiving services. We've also got some studies that we're working on related to the impacts of medication for opioid use disorder and how that might impact family outcomes. So two of our aims.
That sounds great. There does seem to be one question here. Do you think the subsequent abuse is higher because it is more closely monitored?
Yeah, I think that's part of it. And what happens is once families are in child welfare, it may be because of substance use, but subsequent maltreatment is probably often not just that. And so there are a number of things that can trigger a child maltreatment report in this state. And so it could be that it's substance use. It could also be other things, but I think that's probably part of it.
All right. Well, thank you very much. I think that was it in the chat. If anyone else has any, questions or
Lee, there was
comments.
one more question.
Oh, I'm sorry.
from
Yeah.
the
Is there a qualitative piece to the research?
Oh, thank you. That's a good question. We've done a little bit of qualitative research, but mostly related to the teaming aspect of the START teams themselves. And so it's an unconventional approach to have a professional social worker compared with an individual who is in long-term recovery. And then we've sort of learned that can present some challenges about roles and also for the supervisors of these teams. So we actually interviewed all the team members across the state to get a sense of like how teaming works, what makes for successful teams. So we do have one qualitative study related to that. We've not done qualitative work with the families themselves, but that is something that we should definitely think more about. So thank you for that question.
Okay, so let's move on to our next researcher. Thanks again, Martin. Armin, I think you're up next. Is he here?
I'm here.
Here he comes. Okay.
Yeah. Oh, and you can't see me. Hold on. Let me get my Teams is always.
That's okay. I have the same problem.
Yeah. All right. Let me see. I think here we got to switch my camera. There we go. That's me. All right. Thank you so much for the invitation. And I appreciate everyone tuning in to learn more about the work. Dr. Hall is a colleague of mine, and one of the things that he talked about was the ways in which the child welfare system has impact and influence over the lived experiences of the people who live and work around us. And so if there's any sort of parallel to the work that I'm doing, is that I started out as a CPS worker, right? And so that's, if I can share my slides, that's sort of where I will begin. Sure.
I can see them.
Let's swap the display. How's that?
That's good.
Cool. I'm still Armand Perry, still in the School of Social Work and Family Science, and obviously this is a research town hall. I want to spend a few minutes talking about my research trajectory, talk a little bit about some of what I'm calling recent research projects. I guess at this point, some of them aren't as recent as they have been in the past, but talk a little bit about how it is that I've gotten here, where we've been, and where it is that we're headed. And if there's any time left, take a couple of questions. So, as I was mentioning, I'm a social worker by trade. I used to work in Child Protective Services in the long-term foster care unit, which was for us, young people who were in out-of-home care, 14 years of age and older. These were folks who, although their permanency plans were for them to be adopted, and many of them had already had their parental rights terminated, which is what freed them for adoption. If you know anything about the CPS system, the prospects of teenagers being adopted is not very high. So I spent most of my time working with those young people in what we call independent living, which was essentially an effort to prepare them and socialize them to become adults for the day that they will be emancipated from the state of Alabama, where I did this work at the time. So in doing that work, I realized that we did very, very little to reach out to or engage fathers. Most of the work that we did was with mom and by extension, the maternal extended family. And as a consequence of that, I feel like many of those kids stayed in foster care much longer than they needed. And to the extent that we were terminating people's parental rights, we were necessarily separating people from their families without leaving them with many other viable alternatives for social connections and ways to be socialized by people who loved and cared for them. So although I went to school to be a social worker because I wanted to help people, I found myself in what I felt was complicit in a system of oppression. This was particularly given the fact that more often than not, the people that had their parental rights terminated were people of color, and particularly African Americans, without, again, many viable resources being provided to them as alternatives. So that's where my interest in fatherhood stems from. And as you'll hopefully see in the next 10 minutes here, my interest in fatherhood has also led to necessarily an interest in co-parenting and men's romantic relationships, because those are the primary pathways through which men take active roles in their kids' lives. So that's what my work is about. So the first project I want to share with you all is to talk a little bit about the For Your Child project. It's a federally funded parent education intervention for non-resident dads that we operated from 2015 to 2020. It was funded by the Office of Family Assistance, and on that project we served over 1,400 dads across 4 different counties in the state of Kentucky, including Jefferson County, Rowan County, Davis County, and McCracken County. So we sort of got what we felt like was a decent cross section of the state. That project wrapped up in December of 2020, and you can see some pictures there with some of the dads. I think me playing kickball in the park with some of the kids and some of the dads. Some of our outcomes of note here is the statistically significant improvements we see in conflict resolution, and I think most importantly, parenting knowledge. At least as of December of 2021, the National Fatherhood Initiative, which is the organization that produced the curriculum that we use, the curriculum is called 24/7 Dad. At least as of December of 2021, our project was noted on the National Fatherhood Initiative's website for having produced the largest effect sizes as it relates to increases in parenting knowledge. And so that's something that we're excited about and proud of. It's gotten us a good bit of recognition, folks sort of reaching out to inquire about our program model and looking to replicate that in other parts of the country. So that's been pretty cool. You'll see some of the other outcome measures there from that parent education project, which was inclusive of 28 hours of parent education and up to 6 months of what we call solution-focused case management services. And those were attempts to help the dads deal with and address whatever barriers they may have had, internal and external, that limited or prohibited them from being as active in their children's lives as they would have liked. But you'll see some of the other outcomes there, many of them trending in the right direction, but didn't reach statistical significance. Things like parenting efficacy, which has to do with one's confidence in their ability to handle the rigors related to parenting. Co-parenting relationship quality, which is important, and we'll see that pop up again in a slide or two. Conflict resolution, which did reach statistical significance in terms of the dad's improvement in their use of conflict resolution skills, communication patterns. Again, we see trending in the right direction, but not reaching statistical significance. And then last, there's the parenting knowledge, what we've already discussed or talked about. So we spent 4.5 years working with non-resident dads trying to, again, increase their capacity for taking more active roles in their children's lives. And we had some successes, things that I've already mentioned to you that we're really, really proud of. One of the challenges that we had was that the money for that project was earmarked for fatherhood, right? And given what I mentioned to you in my opening, that I got into this work because social services wasn't doing a whole lot with that. The fact that money had been earmarked for fatherhood, I think, is largely a good thing. And we were excited about the opportunity to have participated in that project. However, one of the challenges had to do with the fact that because that money was earmarked for fatherhood, it prohibited us from working with or engaging moms. And since we were working with non-resident fathers, what that meant was many of our dads, even after they improved their skills and knowledge, many of them had difficulty actually applying what they learned in our program because they had to negotiate access to their children with a custodial mom who had not been a part of any intervention. And so that leads us to the next project, which was the Fatherhood Research and Practice Network, Fatherhood and Co-Parenting Study. So essentially what we did was about midway through the For Your Child project, I had dads coming to me and saying that many of them were struggling to apply what it was that they were learning because they didn't have any more access to their kids than they had before the intervention, even though they were a new and improved version of themselves. So we were fortunate enough to have another proposal funded, this time for a much smaller amount, to do some pilot work funded by the Fatherhood Research and Practice Network, which is an intentional effort to connect researchers and practitioners so that they can engage one another and have their respective expertise inform the work of their colleagues in other areas and other realms. And so with this study, what we were able to do was take a trimmed down version of what we were teaching the dads in our fatherhood program and engage those custodial mothers in a one-time 2-hour session that included select portions of the curricula. And you'll see those things listed there. There's a balloon activity, and hopes and dreams for children in co-parenting, what it means to be a man, family history, things like showing and handling feelings, wrestling with grief and loss, which many dads didn't even know that they were grieving the inability to access and maintain active roles in their kids' lives. Many of the dads were responding to grief, but didn't necessarily think about it in that way and had not named it in that sort of a way. So that was an intervention in and of itself, and giving the guys permission to be whole human beings and express the sadness and the lament that they felt for not being able to be as active as they would have liked. But anyway, sessions on communication, parenting time, which many people would refer to as visitation or whatever the case may be, we call it parenting time, and then the co-parenting piece. And so we would do those workshops and then have focus groups with mothers, invite them to engage in no-cost mediation. They were amenable to it. And the idea behind this particular project, again, was a follow-up from what we were learning in our fatherhood, which was we were trying to create or manufacture some receptivity to the idea of co-parenting, right? Trying to create a window of opportunity with custodial mothers, so that they would be more amenable to the idea of working with dad at right around the same time that dad was graduating from the fatherhood program, so that he could hopefully step into that window of opportunity, as I mentioned, new and improved version of himself, making positive contributions to his child's growth and development, so that both he and the child's mother could begin to do what everyone said that they were most interested in, which was doing what was in the best interest of the child, but so often was much, much easier said than done. And so what you'll see here is some of the quantitative results from that particular project. There were statistically significant improvements in the intervention groups, report of conflict resolution skills, and this time we're talking about, again, custodial mothers, right? Reporting statistically significant improvement in their use of conflict resolution skills. Statistically significant improvements in custodial mothers' report of co-parenting relationship quality, and mothers' report of father involvement, again, trending in the right direction for the intervention group, but not reaching statistical significance. But with that project, again, a lot of good work being done there. We were able to get some decent outcomes, a couple of papers published, both using the quantitative data, and then even someone asked a question at the end of Dr. Hall's presentation about the presence of qualitative data. We've had a paper recently published late last year with some of the qualitative data from this project, where the major finding was custodial mothers reporting that as a result of having participated in this project, their empathy had increased. And so, in other words, being exposed to the content that fathers were learning in the fatherhood program served as a catalyst for many of those mothers to begin to think about what parenting looked like from someone's perspective other than their own. And for many of them, given their full-time custodial status, they had no reason to spend time thinking about what parenting looked like. They were busy doing the work of parenting. So to the extent that we were able to help them become more empathetic towards their non-resident fathers, that went a long way into increasing some of that co-parenting relationship quality. And again, helping us achieve that goal of creating that window of receptivity to the idea of co-parenting and working in the spirit of cooperation as opposed to competition. So as we continue to think about what is next, or what has become next for us, is, again, the fatherhood work started with my interest in engaging dads in human and social services and bringing men to the parenting table in ways that approximate the way that mothers have probably always been there. And that led to the co-parenting work, trying to create opportunities for dads to be able to apply what it is that they've learned, and the intervention that we were conducting. But then working with custodial mothers so as to, again, catalyze their interest in taking more active roles in their children's lives and working with custodial moms to help create those spaces. And learning more about the important role that empathy plays in creating what so many of us want to see, which is virtuous cycles of mothers and fathers working together for the benefit of their children, as opposed to what we see all too often, which is the vicious cycle of people leaning into their own individual interests and maybe even pride and selfishness, and only to have the children end up as pawns or commodities in the wars that they have with one another. And so what that has led us to is our team's current project, which is a healthy relationship and essentially pregnancy prevention project, right? So what we're doing with our current project that we call Empower You is we're working with a much younger group of people, 16 to 24-year-olds, and we are providing them with workshops and case management services, all designed to help them delay parenting until they've completed their educations, got started in their chosen career path, or post-secondary education, if that's what they so choose, and have become involved or engaged in a long-term committed relationship. And again, the idea there is to empower, right, those young people to put themselves in situations where they have developed a vision for their future, and they begin to see their futures as one worthy of protecting. And once that happens, the idea of becoming parents before they're ready is something that they no longer see as a part of that vision of future. And so they, again, the idea is that they begin to take steps to prevent that sort of thing. And so that's what that particular project is about. We've been at it for close to 2 years. We have probably, I guess technically about 4 or 5 months left. Actually, when I get off this call, we're talking with the funder about a no-cost extension. So we'll be going probably through the early part of next year. So hopefully there's a research town hall this time next year. I'll be able to come back and share some of the results of that project. So, but that is sort of a brief chronology of the last 7, 8 years in terms of studies we've conducted, services we provided to folks here in Louisville and across the state of Kentucky, and the data we've collected and the ways in which we've attempted to take those data and allow them to inform not only the field from a practice standpoint, but also learning from those results and then allowing them to shape whatever the next project is. And you can see sort of slowly but surely we're getting closer and closer to that prevention piece where we probably need to have started to begin with, so that fewer and fewer people end up needing the services that so many of my colleagues in the School of Social Work and Family Science are providing to folks, or at least training students to provide out in the field. So, of course, have to acknowledge the funders of the 2 studies that we alluded to or mentioned. Super thankful for them providing us with the resources to engage in the work that we've done. I think that is probably close to my time. So we want to thank everyone for their time and attention. If there are any questions, whatever time I have, I'll be glad to try to field as many of them as possible. Again, thank you all so much for the invitation.
Well, thank you so much for sharing that research. I had no idea that we were doing that kind of research here at UofL, and I'm glad to hear it. Does anyone have any questions for him? We are doing pretty good on time, so if you have questions, please put it in chat, or you could actually unmute yourself. It looks like Maria, I think I don't know, I just lost you. Did you raise your hand?
Hi, Dr. Perry. Very interesting. And I'm in Department of Psychological and Sciences. I'm a linguist, and I'm looking at language environment of children in their home, at their home. So we use technology because language environment affects how children develop. And I sent you an email like yesterday, I think, because we also started to look at fathers and siblings and their interaction and social roles that they contribute to the development of children. So have you ever thought about looking like from like at communication, like language communication side, like what mothers and fathers are doing, because that contributes to the overall child development as well. So, and yeah, I would like to maybe meet with you sometime and just chat more about it. So that's.
Absolutely. The first thing I want to say is I saw your email and I owe you a response. I gave my final exam this morning, so I'm knee deep in grading. As soon as I can and get that wrapped up, I'm definitely going to be responding to you. To your point, I think your work is really, really important because children and child outcomes, I think, that's our reason for being, right? So we work with dads, but we work with dads because we're trying to increase their capacity for taking more active roles in their kids' lives, because we believe and we know there's a body of research that supports the idea that when dads are actively involved in their children's lives, it tends to be connected to or associated with better outcomes for children. So the work that you're doing is really, really important because that's where the rubber really, really meets the road. I'm also familiar enough with the child development literature to know that there's a body of work that talks about the important but unique and distinct contributions that fathers make, right, in terms of child development, the encouragement of confidence and competence through rough and tumble play and so on and so forth. And so I would imagine that to the extent that dads tend to communicate differently than moms, that there may be some
that's what we are finding in our research.
Yeah, absolutely. So I'm sure that there are some unique sort of findings there. So I'd love to collaborate with you, and we'll definitely be following up as soon as I can get as soon as I can click post on my final exam scores later on this afternoon or maybe this morning before the university sends me a sternly worded email about how long it's taking me to get those things done. So it's great to meet
thank
you.
you both.
Yeah.
I just want to cut in because we do have one more speaker, and we are starting now to get, some time limitations. And I want, Patrick to really go over and share with us the exciting work he's doing. And I'm also happy, though, to say that this is a venue that we're hoping will help faculty find other connections to other researchers on campus. And so I think, this is a great thing that Maria, is interested in talking to you. And so, this makes me feel good today that this is actually not only helping to inform what's going on in our research on campus, but also helping us to find collaboration. So, all right, I'm going to turn it over real quickly to Patrick. And Patrick, take over.
Thanks. Before I start with what I have to talk about, I find the research very interesting as well. One of my longest standing research areas is actually prevention. So I'm really thrilled to hear that you want to move now in prevention. So my presentation today is slightly different. I want to talk about research on rumination as mechanism underlying mental health and physical health, or basically the comorbidity. But because I think many of us don't actually think about all the variables I want to talk about and the relationships, so I will talk more at the end about the research that we are currently doing and more about the constructs that I'm researching. So let's see that I can move. So number one, physical and mental health. So I think the most of us will agree that we see physical and mental health nowadays as maybe two sides of the same coin. But as soon as we go a little bit more into detail, we might have slightly different ideas how that looks like. So one of my main outcome variables that I'm usually studying is depression. And so I think the most of us would probably agree when I talk about something like depression and sleep. Yes, sleep impacts our mood, so sleep problems lead to depression. Depression impacts our sleep pattern. But when I start talking about cardiovascular health and depression, many of us might go, what? So let's go maybe through a couple of examples here. I think the most of us will still be on board when I talk a little bit about that. For example, when you have a cardio or when you have a heart attack, that the risk to develop depression increases. I think that makes a lot of sense for many people, but I don't know how many of you actually knew that people with depression have, for example, a 40% higher risk to develop cardiovascular disease. Another, I think, very interesting study actually compared the traditional risk factors like smoking, like a lack of exercise, so the traditional risk factors of cardiovascular disease, with the impact that depression has, and found that depression and smoking actually increased the risk for cardiovascular disease on a similar level. Quite impressive, isn't it? So that's just a few reasons why actually the American Heart Association now actually multiple years ago added depression as one of the main risk factors for cardiovascular disease. But whenever I see a bidirectional relationship like this, or a circular, if you want to if you prefer that term, then I wonder if it's possible actually that the same mechanisms underlie this. And now I see that I forgot to make a change here. But so just to give you an idea what might be reasons for those associations or for this appearance that there's a bidirectional relationship. We know, for example, that low-level chronic systemic inflammation is a risk factor for both cardiovascular disease and depression. When I look at this, and I don't know if you don't know me, my background is psychology, I always wonder if there's a psychological factor, of course, so that it connects to me and what I can do. And we know that chronic stress increases low level, or increases the risk for low level chronic systemic inflammation. So just because I will need this in my last slide, chronic stress also elevates, of course, blood pressure, which then is associated with cardiovascular disease. So now the question is, of course, what is actually chronic disease, chronic stress, and what triggers it? Since COVID, I always use the same example. COVID. I was in the privileged position that I was sheltered at home, so I didn't have to go to the clinic. I didn't have to carry the trash away from strangers. I didn't have to deliver food to people, so I was safe. But still, we think that being sheltered at home is actually, or was actually, a chronic stressor. And no matter where you are on this debate, if COVID was really bad and killed people, or if you thought, no, that's all exaggerated and people make that up. What usually happened during this period, and still happens to a certain degree, is we watch news, we read a newspaper, or scroll through our social media, and we hit a piece of information. Of course, our stress level goes up as we process it. But usually the stress level should go down as soon as I put my phone away or put the newspaper away, as soon as I turn off the TV, right? So that sounds more like short episodes of stress. What makes it chronic is actually that now I return to work, but while I'm working, my brain is still working on, oh, what's actually going on with COVID? What's going on in our society with it? Things like this. So basically, what makes it chronic is that it keeps running in my head. And that is what we call rumination, or to be more specific, habitual or trait rumination. And we use this habitual or trait because I can induce in all of us something that we call state rumination, basically something that you respond to for a few minutes. And what is meant with trait and habitual is it is ingrained in us, so we do this on a habitual level. One more thing, we also know that rumination is, for example, a good predictor for depression. This is actually where the construct of rumination comes from. as a risk factor, as a predictor of this depression. And then our work group and work groups around the world could demonstrate by now that rumination also influences not only through chronic stress, physical outcome variables, but also directly. So it leads to or keeps elevated blood pressure up, and it is associated with certain elements of the immune system. So let's talk a little bit for a second about what habitual rumination is. So when you find yourself overthinking about situations, problems, or feelings, when you notice that it's hard for your brain to slow down, when you experience intense emotions for longer periods of times, so like what I just talked about with the example with COVID, when you avoid or not finish tasks, so basically when we procrastinate, when we are not falling asleep or stay asleep, it's this situation you wake up and usually we fall asleep again, but then our brain starts to run, right? Go through our problems. Or when we notice physiological responses that don't fit the situation, like when my heartbeat increases without physical activation. So now the most of you, statistically speaking, should go and say, hang on, what? So at least one or two of those things hit probably the bill. Yes, we are all somewhere on this dimension, how much we ruminate. There are barely people that don't ruminate at all. But basically, the important thing is how far on the extreme end of ruminating a lot are you? So now let's talk a little bit so far I talked about what rumination is and the associations we know, but what we don't know and what the next steps are is obviously the next step. So research to habitual rumination, not the state rumination, but habitual rumination and physical outcomes is almost exclusively correlational, so cross-sectional or longitudinal studies, meaning as we don't have experimental studies, we cannot really draw causal inferences, right? That raises the question, can we actually change habitual rumination and how we do this? There are at least two quite well-established approaches to do this. And when you're aware of psychotherapy, then you see in an eye blink, both of them are psychotherapeutic methods. One is called mindfulness, and the other one is called rumination-focused cognitive behavioral therapy. So we know we can change habitual rumination. The most studies using those approaches do not include underserved populations. So we know studies to habitual rumination and that use rumination and depression as outcome variable, but many of them use student populations or people that can afford psychotherapy. So this is one of the things that we will do in our upcoming studies. We will focus actually on clients that are or underinsured. And with that, I come already to a study that we hope to start in May or June. It's basically a proof of concept study using a single subject design. So I talked already about the uninsured clients, and we select them out of, or we are looking for clients that have elevated blood pressure, higher levels of rumination, and higher levels of depressive symptoms. Makes sense, right? This is what we want to reduce. Our outcome variables, rumination and depressive symptoms, and we hope, of course, that we can replicate what the previous studies found. But we also look into blood pressure and then cortisol, HCRP, interleukin-6, and TNF-alpha in saliva. Cortisol is quite obvious, I hope, for some of you. It's a stress hormone. We would expect that goes down, and the other ones are related to the immune system. So that's basically our outcome variables where we make the first step. If we change rumination, do they go down? So that's basically this experimental part and the causal inferences we can draw. And then the next logical step is, of course, to do a bigger study, a randomized control group study, that some NIHs would call mechanistic clinical study. Basically, we focus on the mechanism, we focus on rumination and see if the outcome variables follow. So now I was talking quickly. I hope that I kept us in time by doing so. Thanks for your attention.
Thank you, Patrick. Like I've talked to you individually before, I totally like this idea. And as a ruminator, I can tell you this worries me that I'm going to end up with cardiovascular disease.
That's so nice that you jumped from rumination to worry. If I had more time, I would talk a little bit about the differences. But in general, yes, thanks for pointing this out. There are different terms that you might know this process is under, and we are all ruminating a little bit.
Okay, so we're a little over the time. Does anyone have any quick questions for Patrick? Okay, well, if you think of anything, I'm sure you may email him, with any questions that you may think of after today. And then I will just mention, I put it in the chat, tomorrow is our drop dead deadline for the upcoming May 16th NIH seminar that we're hosting. And that is open for, any active full-time researchers. And so that includes faculty, postdocs, and graduate students. So, please share the information. I will say, as of this morning, we have 91 registrants, which is awesome. So for those of you that may have already registered, you may get another notice. We may be moving it to a different venue due to the interest that we have on campus. But it's exciting. We're very happy that, people are interested in joining us for that. All right, if nobody else has any questions, then I'll let everyone go. And as Kevin said, happy Derby. And I hope everyone gets through their classes and gets their grading done. And like I said, we'll circle back in June with another town hall. Okay, thank you, everyone.